Namaskar and greetings, everybody. My name is Dr. Nandi. I'm an IBD physician here in the United States, and today I have the great honor of inaugurating the first episode of SAIA's second season here on Facebook Live. I am joined by some wonderful patient advocates and South Asian IBD professor, Dr. Vineet Ahuja. I'm also here with with Madhura Balasubramaniam and also Tina Aswani-Omprakash. Welcome to the program. Perhaps a brief round of introductions. We'll begin with our chief guest, Dr. Vineet Ahuja. Dr. Ahuja, can you please tell us a little bit more about yourself?
Thank you, Neil. It's a pleasure, honor to be part of this program and pleasure and honor to be associated with the society. I'm a professor of gastroenterology and associate dean research at All India Institute of Medical Sciences, New Delhi. We run the IBD clinic out there and we cater to a very large cohort of patients, around 7,500 patients on our follow-up. And so on an average, we see around 200 old patients a week and 25 new cases a week. And we do get a lot of challenging cases in terms of cases not only who are diagnostic issues, but also cases whereby who are very aggressive and they do require high-end therapy. We have patients who can afford the therapy. We have patients who cannot afford anything at all. So it's a whole spectrum we've got to deal with. But at the same time, we do try our best to take the best possible care for our patients. Thank you, Neil.
100%. And no doubt you are a high volume center, you are also a very humble individual. For those of you who may not know, Dr. Ahuja really is a professor in every sense of the word. He's an IBD expert and a massive publisher, very knowledgeable, and we're really lucky to have you here at the South Asian IBD Alliance program. We have two patient champions, Madhura and Tina. Please introduce yourselves.
Oh, Madhura, go ahead.
Okay, sure. Hi, everyone. Good evening from India and good morning to those who are tuning in from the US and other parts of the world. I'm Madhura. I'm a Crohn's disease patient. I was diagnosed in 2019, and I've been on many of the therapies that we're going to be discussing today. I'm a proud member of the South Asian IBD Alliance, SAIA, and I'm so honored to be working with all of the amazing physicians and patients on our team. Thank you so much, Dr. Ahuja, for agreeing to join us today. And I'm very excited for us to talk all about IBD medications and how we can address some of the common questions that we get from our patient community. Thank you. Tina, do you want to go next?
Yeah, thank you so much, Madhura, Neil, Dr. Ahuja. My name is Tina Aswani-Omprakash. I'm very excited to be here with you today and to, have such wonderful guests, Dr. Ahuja, Madhura, and Dr. Nandi moderating our chat. One of the questions that we get a lot in our group is really around therapies, safety of therapies, longevity, meaning how long we need to take these for. We just thought it would be a good opportunity to share with you all some of our doctors' recommendations and thoughts and training and what they are, suggesting to their patients based on a variety of different cases. But also some of the patient experiences. So Madhura and I are here to provide the patient experience, and I'm very excited to have Dr. Ahuja provide his experience from India, and Dr. Nandi provide his experience from the United States. Thank you, everyone.
Thank you, Tina. And again, thank you to all our entire guests. If you're just tuning in, we're just kicking off the first episode of SAIA's second season here on Facebook Live. Here as part of the Patient Outreach Advocacy and Committee, Madhura and I help co-direct that program. We try to set out to get the most pertinent topics that we derive from our community. So if you have other topic and ideas and suggestions, please send them to us in the chat. Also, during this live, please, provide us any of your questions. If you're attending, you know that today we're talking about one of the most important things, right? Which is, what are the new medications and how do we gain access to those medications? And depending on which part of the world you are in, there's different challenges to medication access. So first, we want to talk about what the medicines are, when to use them, when to talk about surgery, which is an extremely important tool in our kit, and talk about access issues too. So first off, why don't we, begin with Dr. Ahuja. Can you please give us kind of an overview, just a general overview of the different types of medicines that are available to us as patients in treating inflammatory bowel disease?
Thank you, Neil. So, if you had asked me this question around 10, 15 years back, I would have said we have just mesalamine out there and infliximab is just being introduced. And that is all. Cilazoparin, mesalamine, and then you have prednisolone. Nothing more than that. Today, if I look at it, we have a variety of choices which are available, a variety of medicines in our armamentarium in which we can decide, okay, if this is not working, we can start this. If this is not working, we can start this. So for mild patients, we have the various mesalamine preparations, we have sulfasalazine. Then coming on to steroids, we have budesonide, which is getting released in the small intestine, the controlled release preparation. We have budesonide MMX preparation, which is released in the colon. We have the regular prednisolone preparations, which are there. Moving over to biologicals, we have infliximab and also the infliximab biosimilars. We have the adalimumab biosimilars. 3 or 4 companies are producing it. We have lymphocyte trafficking inhibitor, the vedolizumab. We have Stelara or ustekinumab. In terms of oral small molecules, we have tofacitinib. And that too in generic forms. When I say generic forms is that there would be 10, 15 brands available and it would be really, really very cheap. The cost of tofacitinib in India would be something which would be the cost for 5 years or something like that. So the only 2 drugs which I think are no, and the topical preparations, we have the mesalamine suppositories, the mesalamine enemas, the steroid enemas. So if I look at it, there are only 2 medicines which I can think of which are not available in India today. That is, one is upadacitinib, second is ozanimab. Rest everything is available. So that way it's a good thing for the patients that we do have a lot of choices. Yet at the same time, I would say there's a paradox of choice. There's so many things that you have to be careful in terms of deciding what to start first, not to be exuberant in terms of starting absolutely the strongest medicine, thinking about that what a patient can afford, what are the side effects, the right patient, the right drug. So it's a kind of decision for which today the physician needs to exert a lot of wisdom. Earlier, the physician had only 2, 3 choices. So he could decide the gastroenterologist, this or that. Now there are 10 choices. Yet at the same time, when I say paradox of choices, does it convert into 100% happiness? Then no. Why? No, because we have not found out the cure for the disease. What we are doing is just sequencing drugs. We are controlling inflammation. So till the point we find out what is the cause of the disease, what can actually cure the disease, we do have a lot of agents available today which can control inflammation to a certain extent. Thank you.
I think that was a great overview, and it's nice to know that we have so many available options in South Asia that patients can access. So it's not a limitation that the medication isn't there. It's there, and it's important that as a patient that you connect with a gastroenterologist, particularly a Crohn's and ulcerative colitis specialist as yourself, in order to get that kind of access, from a clinician who knows how to use the medicine. Before we get into the depth of steroids, thiopurines, biologics, and then small molecules, before we get into that very granular detail, maybe we should take a bird's eye picture and ask, who needs these medicines, right? What's the right timing and access for these medicines? When do you start? What's the threshold to start a biologic or small molecule in lieu of a steroid in a patient who has Crohn's or ulcerative colitis?
Okay, Neil, here I would like to divide into 2 parts. That is a patient with ulcerative colitis and a patient with Crohn's disease. Since Crohn's disease is a progressive disease in terms of moving very fast from an inflammatory phenotype to developing strictures to developing fistulae, so there the gastroenterologist has to be very careful in deciding right from the beginning whether the patient has an aggressive phenotype or the patient has a milder variety of disease. And that can be easily made out if the patient has a stricturing disease or a fistulizing disease or has a small intestinal disease, a younger patient with a previous history of surgery. So obviously the question is not of starting mild form of therapy, but straight away going for a higher form of therapy. Second thing is that in a case of Crohn's disease, the if a patient has an aggressive disease, the earlier you start biological therapy, the more the patient would benefit. At the same time, if I take a case of ulcerative colitis, in a case of ulcerative colitis, a top-down therapy that is starting biologics early on in the course of disease is not going to help. It has been shown that it does not change the natural history of the disease if you start on biologics too early. So if I have a case of ulcerative colitis, I would always start the case of a patient on 5-aminosalicylates. If the need be, move over to steroids. And if the need be, move over to the patient to azathioprine. Generally, the patients do well. 5 to 10% of patients may require biologics, and that is fine. And at the same time, remember that surgery is a very good option there. As gastroenterologists, what we do is, and as physicians, as the patients also, since it's a 3-step surgery, so they feel that surgery is as avoidable as much as possible. But remember, in ulcerative colitis, surgery is also curative. So if you have a patient support group where you have 10 patients who have undergone surgery, and at the same time, you will realize that 8 of them are doing very well. So they will provide that positive experience to the patient, which would really help them in taking the decision. In Crohn's disease, again, if the patient has a mild disease, a colonic disease which is mild, then they can be started on azathioprine. Many of our patients are on 5-ASAs also, even though the guidelines do not suggest that. But what we have seen, if a patient has mild Crohn's disease, you start on 5-ASA and you monitor the disease that there is no progression, then some of the patients do well. But majority of them, we do move on to azathioprine or methotrexate. Patient is not responding to azathioprine, we move over to biologics. But as I told you before, if a patient has a very aggressive disease in terms of stricturing or fistulizing disease, we move on to biologics very fast or straight up. So here again in Crohn's disease, surgery is an option. And that is where I think that we should also ask Tina and Madhura, these are two things in terms of that. What do they feel about surgery in a case with Crohn's disease? Because as you and me often say that even in patients with Crohn's disease, surgery is not curative. Disease does recur. But I think it still has a major role to play. So with your permission, can we ask them their perspective about it?
Please.
That's a great
you should
question.
take that.
Okay, sure. I think that's a great question, Dr. Ahuja. So just for a little background, I was initially diagnosed with ulcerative colitis. It went from mild to very severe very fast. I was given surgery as in the toolkit as a treatment option. And I was also told not to consider this a last resort, that this is really a treatment option and it can be largely curative of my ulcerative colitis. What had happened was I underwent the surgery with a lot of pushback from my family. And we do hear this a lot in our community. This surgery is very stigmatized. Many of us do end up with an ostomy, at least temporarily, before we get a J pouch in ulcerative colitis. Unfortunately for me, it actually did turn out to be Crohn's disease, and my J pouch had chronic refractory pouchitis even before takedown surgery. So it did not turn out to be curative for me. That said, I've had many surgeries since then for reversing the J pouch, giving me an ostomy, for dealing with fistulae, abscesses that I was having over and over again. And I will say that, during a time when I was not responding to biological therapies or some of the mainstays like azathioprine back in, 2008, 2010, 2012, I was not responding to a lot of these medications, and we didn't have some of these newer therapies out. Surgery really did help to control a lot of my symptoms, bring me into remission. And with Crohn's disease, many of us do need to be put on a post-op biologic or a post-op therapeutic to make sure that our disease doesn't continue to spread or doesn't continue to fistulize or stricture. And I've been doing much better since then on a biologic therapy with an ostomy. And I just want to assure you all that surgery is not as scary as it sounds. It actually has really given me that life back and given me the ability to eat again, and to put on weight again, given me the ability to work again and help to run SAIA. So these are all, the pros of both medications in IBD and also in surgery. These are all a variety of tools that our physicians are using to get us better.
Madhura, what kind of perspective or opinions do you have in regards to surgery? How do you approach that from your own patient journey?
I think that's a great question. And like Tina said, I think from the beginning of my diagnosis to where I am today, I've seen myself change my perspective on surgery. It sounds so scary, like for a newly diagnosed patient to be told you might need surgery in the future. It is very terrifying to think about. And I think that feeling of fear is fair. But I would strongly encourage our patients to listen to other patients who have undergone surgery, who are seeing that quality of life improvement, and to kind of start thinking about surgery as part of a treatment toolkit. So we have these different medications that Dr. Ahuja laid out. We've got the 5 ASAs, we've got the steroids, we've got the biologics, we also have surgery. For me, what has also been very reassuring to read is some of the recent research that's happening on surgery itself. So there is the recent LYRIC trial that was published, which is looking at how do we think about surgery as part of the treatment toolkit. And they found that there are patients who are doing so well post-surgery that they don't need post-op medications as well. Now, who are those patients who benefit in that particular way is something future research will show us. But what the preliminary results are telling us as patients is that we don't need to be scared, that surgery can give us our quality of life back. It can help us do all of the things that we want to do. So for me, having access to patient advocates like Tina and reading her journey through her blog and through her work through SAIA, as well as some of our other patient advocates on the team, as well as reading all of this research, makes me feel reassured that surgery can be thought of as part of treatment rather than thinking about surgery as what you do when everything fails. It's one of our many options.
In fact,
I totally agree.
Yeah, Neil, to add on to that, last week only a very good paper has come out from Mount Sinai, which has looked at the population-based data to show that how surgery works very well for ileocecal Crohn's disease. And in a way, that paper is very important, okay, for the Western population, but in India, for Southeast Asian population, that paper is even more important because at times tuberculosis and Crohn's disease, they resemble alike, and you don't know what you're treating. So surgery not only gives you the diagnosis, but it also helps you in treating the patient. So it works both ways.
Absolutely.
Now, here, the third thing which I'd like to bring in is that we restrict ourselves to being treated by gastroenterologists. You suddenly realize that 2 of our topmost patient advocates talked about surgery. So it tells you that surgeon is has a very important role in IBD management. The list does not stop out here. Actually, today, IBD care is multidisciplinary. Your biologicals are not going to work if the patient has a low albumin level or the nutrition levels are poor. So you need to have a very good nutritionist in the team, or as a patient, you should have access to a nutritionist that will take care of not only the albumin levels or something, it will take care of the sarcopenia, or what is the loss of muscle mass. It will take care of what is known as sarcopenic obesity. It's not necessary that IBD patients would be frail. Some of the IBD patients can have a lot of visceral obesity also. And if the patient has a lot of visceral obesity, that could also lead to bad long-term outcomes. So nutritionist is also very important. Similarly, you need to take care of other peripheral stuff like vaccinations, bone health, anemia. A psychologist is necessary so as to keep you upbeat. It has to keep you optimistic. It's a chronic lifelong illness. So you need not get bogged down by it. So in other words, the team has to consist of 4 or 5 people. Yes, traditionally gastroenterologist has been the most important person. But if you want top quality care today, most of the good IBD centers would have access to these, would have these or 3, 4 people who would make a team. And as a patient, I think you should from yourself take active steps in going and meeting each member of the team so that you can get the best possible care.
Dr. Ahuja, I think those are great points. And I want to bring back the interdisciplinary need back to our medicines and give some highlights of all the comments that each of you all made. So for our audience out there, the reason we need an interdisciplinary team, dietitian, surgeon, mental health therapist, and more, is because the toll of the illness left untreated, or even when treated, right, can affect malabsorption, growth, strength, mental health, and more. So coming back, a couple of key highlights for you to take home in the audience is Dr. Ahuja highlighted there's a difference in how we treat and manage Crohn's and ulcerative colitis. In ulcerative colitis for mild to moderate disease, there is a proven role for non-immunosuppressive therapies such as mesalamines, whereas in Crohn's, our meta-analyses do not demonstrate efficacy. However, I agree with Dr. Ahuja. In my own clinical practice, there are very mild, just inflammation, tissue erythema, redness, Crohn's patients who might respond to mesalamines. And so there is some anecdotal use of that. But by and large, from mild to moderate, you see the good news for our patients is that mesalamines do work and do work well to induce a remission. And then Dr. Ahuja highlighted, and something our patient advocates reflected upon is the role of surgery. In ulcerative colitis, when we have the most severe disease, colectomy, I wouldn't say curative, but can actually remove the burden of disease, and you trade the state of ulcerative colitis and bloody diarrhea for another state where you may have you're in continuity, you have a J pouch, or you may have an ostomy. But either way, you may trade your state of flaring and malnourishment for another state where you do not have that, but you deal with an ostomy or some chronic pouchitis, but your life is moving forward. You're moving forward with life, whatever you want to do in life. And then similarly for Crohn's, if you have endpoint complications of chronic disease that result in stricture or fistula, there's a role for surgery that gives you back your life by resecting the surgery. Madhura, I love how you brought up the lyric study, and Dr. Ahuja announced that Mansi Agarwal at Sinai reviewed some of this post-op data. And, we can't predict who's not going to need surgery, but it highlighted that there is a subset of patients who will benefit from surgery and may not need post-operative immunosuppressants. So gosh, look, in the last 10 minutes alone, we've highlighted some great caveats and nuances of how we approach IBD. I really want to have our audience kind of get into the discussion of, what are these biologics and what are these molecules? What's the difference? And who might be a candidate? How good are they? How efficacious are they? Do they work? And what are the safety risks? So why don't we ask Dr. Ahuja now, if you kind of mentioned it earlier, what's the difference between a biologic and a small molecule and a thiopurine or methotrexate? To the lay person, they may sound similar. What are they? How are they different?
Well, biological is something like an aeroplane, and a small molecule is like something like a bicycle in terms of complexity. It's not necessary that they may not be, the effect may be that they may not be that much different. But in terms of complexity, as the name says, small molecule. So it is something very easy to make. It's a hydrocarbon. A biological is something which is a protein. It's like if a living cell is producing a protein, you want to make antibodies against it. So that is where the biologicals have come in. So biologicals are something which are very targeted. They would attack one particular cytokine or may attack two cytokines, like the way ustekinumab or Stelara does it, right?
Dr. Ahuja, I'm gonna interrupt and ask you to clarify a point that comes in from our community often. Yeah. Sometimes there's a perception that biologics, because they're given intravenous or subcutaneous, that they're considered chemotherapy. True or false? Are biologics chemotherapy?
No, biologicals are not chemotherapy. Chemotherapeutic agents like azathioprine and methotrexate which are used now much less commonly as compared to biologicals and all. Azathioprine and methotrexate were earlier used as chemotherapeutic agents because they would control the growth of T cells, or what are known as even the cancer cells. They would stop the growth of cancer cells and all. Right? Biologicals can be chemotherapy, particularly if they are, let us say, against the epidermal growth factor, vascular VEGF or something like that. However, when we talk about biologicals which are used for IBD patients, they are not chemotherapeutic agents. They control the immune responses, but they have very specifically, they control particular cytokines. They are targeted therapies. So yet at the same time, they do decrease the immune responses. As a result, a person is prone to infection, which after a chemotherapeutic drug, also a person may be prone to that. Now, let's say talk about azathioprine and methotrexate. They're simple molecules which were used in late 1980s, late 1990s, and still are being used because they do have a good amount of efficacy. The only thing is that since we have better drugs available, so the moment they lose the efficacy, we switch over to biologics. Small molecules like tofacitinib have come up over the last 3-4 years. Prior to that was a decade of biologics, where you had anti-TNF inhibitors like infliximab or adalimumab, and then came up vedolizumab. So biologicals, they will have antibodies against a particular cytokine. That cytokine would be causing a lot of inflammation, something like TNF. Biological would go and control that inflammation. As a result, with the dampening of the immune response, the symptoms would settle. Now, the problem with biologics is that since it is a protein, so as a result, there would be antibody formation against it also. Since there would be antibody formation against it, there would be a loss of response over a period of time. Either initially they would not act or there would be a loss of response. In fact, for all IBD therapies, in a way, the sad part is that none of them is 100% effective. Most of them, as a rule of thumb, are 60% efficacious. Whether it is 5-ASA, whether it is azathioprine, whether it is a biological, whether it is tofacitinib. On an average, they would be efficacious in 60% of the people. That is why you need to keep on jumping from one therapy to another therapy. So biologicals lose their response because antibodies can be formed against them. Secondly, the biologicals, since they are so tough to produce, so as a result, they also need to have cold chain conditions. They need to be stored very well, and they have to be given intravenously because they will get degraded in the stomach. Whereas oral small molecule, the typical example is tofacitinib, very easy to produce. Since easy to produce, so in India and all where the patent laws may not apply, so generically they can be produced. So as a result, their cost is very low as 5-ASA. Biologicals, even if you're making biosimilars, are still very tough to produce. Then oral small molecules, since they can be given orally and at the same time, they're very fast acting. They would act within 3 days. Tofacitinib may start acting in 3 to 4 days. A biological would take 7 to 10 days to act. Upadacitinib may act within 1 day. Vedolizumab will act within 24 days. Stelara may take 2 to 4 weeks to act. Whereas these oral small molecules, they, as I told you, they act within 3 to 5 days at most. So they're very fast acting. But at the same time, they cover a lot of targets. Since they cover a lot of targets, a lot of cytokines, so the side effects are also more. They are not very specific. They would be acting somewhere in the liver. They would be acting somewhere in the kidney. They would be acting on many cytokines. So the side effects would also be more. So the small molecules, easy to take. They are oral. They are very fast acting. They are very cheap in countries like India, but their side effects may be more, and at the same time, they may have some good effects, some bad effects. Biologicals, they're very targeted therapy, but at the same time, they're complex molecules, so you need some cold storage conditions. You can give them only intravenously, although subcutaneously you can give them. There is an oral version of vedolizumab, which is also in the phase 2-3 trial. So if it becomes successful, excellent, fine. Otherwise, still now they're intravenous or subcutaneous, and also because they're complex to make, so very expensive. Yet both are required.
I had a quick question, a couple of summary points and a quick question. And some of these questions, I think our patient advocates might be helpful in understanding their perspective. But just to highlight what Dr. Ahuja just said, just to recap, biologics may be, given IV or subcutaneous by syringe injection. Some of the biologics, specifically the anti-TNFs like infliximab, patients can develop antibodies against, where your body rejects the medicine, essentially. But the other modern biologics like vedolizumab, vedolizumab and ustekinumab and risankizumab which is not available, I don't believe, in South Asia yet, risankizumab, okay. But those biologics, there's much less rate of developing antibodies against the medicine. And when that rarity happens, it doesn't seem to have much clinical impact on the efficacy of the medicine, fortunately. And then again, this is in contrast to what Dr. Ahuja was talking about, small molecule therapies like tofacitinib, which is not a biological protein, so we don't develop antibodies against it. Now, a couple of questions came in, and I wonder if our patient advocates can ally or relate to these questions. Are the oral meds, this is a question that came in for anybody to answer, are the oral meds, such as the new small molecules, enough to treat extra-intestinal manifestations, right? So we talked about efficacy of the biologics and therapies, about 60%, which means 40% of the time they don't work. What's the efficacy on extra-intestinal manifestations such as arthralgia, uveitis, oral ulcers, or erythema nodosum?
Do you mind if I take that?
Go for it.
Dr. Nandi, I think, just to provide the patient experience, there are some extra-intestinal manifestations that are, directly correlated with IBD activity. And then there's some extra-intestinal manifestations that may not be as correlated. They're kind of part of that general autoimmune umbrella of, something sort of acting out when it wants to, so to speak. At least that's my understanding based on what my physicians have told me. So for me specifically, I had erythema nodosum, which is a skin condition. It looks like a mosquito bite, but it hurts a lot. I also had pyoderma gangrenosum, which is some kind of necrosis that happens on your skin. I also had hidradenitis suppurativa and sweet syndrome. Those were all resolved once my Crohn's was better controlled on a biologic. And that they were all sort of acting out as my Crohn's got worse and worse and worse, as I developed fistula after fistula. That was my experience. Same with the arthralgia. The inflammatory arthritis that I developed was directly correlated with the severity of my IBD. Whereas the episcleritis, which is an eye condition, many people develop iritis or uveitis as well, did not always correlate with IBD activity. So sometimes I would have to just standalone treat that with a steroid eye drop. I was also treating some of these dermatologic manifestations and arthralgia with steroids to try to get by a day-to-day until the biologic kicked in, for instance. So that was my experience. I understand the small molecules, and I'd love to hear from Dr. Ahuja and Dr. Nandi on this, and also from Madhura about her experience with extra-intestinal manifestations. But my understanding with the small molecules, especially with upadacitinib, there is some sort of, there is some data showing, also from Mount Sinai, showing that perianal fistulas, perianal disease seems to be treated by upadacitinib. And I know that some of that can come with extra-intestinal manifestations. So I'm curious to hear your thoughts, Dr. Ahuja, if you want to take this next.
Okay, like in terms of when we talk about extra-intestinal manifestations, as Tina, you very rightly said, some of them are associated with activity of the colitis, IBD thing. Some of them are not associated. Like typically ankylosing spondylitis may not be associated. And because, so when we talk about tofacitinib and upadacitinib, they do take care of extra-intestinal manifestations also. When we talk about biologics, anti-TNFs, they do take care of extra-intestinal manifestations. Vedolizumab is not very good at taking care of extra-intestinal manifestations. Ustekinumab is very good at taking care of extra-intestinal manifestations.
Yes.
When we talk about perianal fistulae, still the best drug for perianal fistulae remains. Again, it requires multidisciplinary care. A surgeon has to be on board to put a seton thread if there's a complex fistula. In addition, biological like infliximab or adalimumab still remain the first line of therapy. You're right, very right, that upadacitinib has been shown to have some benefit out there. At the same time, tofacitinib has no role to play in Crohn's disease. It was not found to be very effective in Crohn's disease, so there it may not be used. But so in general, if there are AIIMS, if a patient is of ulcerative colitis, then one may go in for tofacitinib or anti-TNF. Whereas if it is a case of Crohn's disease, and again anti-TNF or ustekinumab, and if upadacitinib is available, then one can go for that. Would that be fine? But Neil, can I have a question for you, please? Since you seem to be getting away in terms of only asking us questions, can I ask you one? So,
Sure.
is it true that in US, people are using less and less of azathioprine and jumping the step of azathioprine and straight away moving from, you can say, 5-ASA and a short course of steroids to Biologics? Is it correct?
I think I don't know if there's an official study on trends on prescription refills, but I would say that yes, we at least my own practice, I'll speak from my own clinical practice, that I have a large number of patients on thiopurines, way more than methotrexate, honestly, because methotrexate's side effects are the rate limiting factor. and it's not effective for induction of remission, for instance, in ulcerative colitis or Crohn's. However, thiopurines, I do have a number of patients who've been in long-term remission. I think it's the risk factors or the side effects long-term that make us think twice about like decades-long therapy. And so depending on how the shared decision-making goes with the patient, we may broach the subject of, apart from the idiopathic side effects of like pancreatitis, et cetera, non-melanoma skin cancer being increased. We have patients who often have many non-melanoma skin cancers that need to be removed at the dermatologist's office. So that is a real playing factor. They get tired of all these skin biopsies and skin removals. And then also there's very small risk of hepatosplenic T-cell lymphoma that's only slightly increased in combination with a TNF. Those are patients, if they started as pediatric males, though that's a subset of population that I target and actively try to transition away from a thiopurine onto a biologic, because I want to avoid that, even though it's rare. But when they have risk factors of pediatric age, been on it for decades, I try to focus on that. Because we see also the other thing that, and again, I want to say, Dr. Ahuja, thank you for asking me the question. I appreciate that. I was going to say sometimes the necessity of the severity of our patient, right? When you have a sick patient who's flaring in the hospital, high dose steroids, the thiopurines take a long time to work, right? They take anywhere from 8 to 12 weeks to peak, and then you have to do some dose titration, 3 to 4 months to actually imbue an effect of healing. It's a long time. So the nice thing about the biologics and small molecules is they're far more rapid in their action and getting that patient back on track to a steroid-free remission, and either avoiding surgery or using surgery in combination with the biologic for a longer-term remission. So the short answer is yes, at least we have been trying to go to a biologic or small molecule a little earlier than just going on to a thiopurine. Now, I'll have one other caveat, which is when we look at the patient with fistulizing Crohn's, which is one of the most significant manifestations and life-altering manifestations of Crohn's. In that population, the data for combination thiopurine and TNF is very valuable in healing. And so, that is a patient population that we still utilize thiopurines in my practice heavily in combination with the TNF.
So you think that the oral small molecules are the new steroids?
Great question. If you're asking me, I am particularly excited about the selective JAK inhibitor, specifically upadacitinib. I have a number of patients on off-label upadacitinib. In the United States, upadacitinib is FDA approved for ulcerative colitis and newly approved for Crohn's. And I've been using it off-label for a number of years now, 2 years or so. And I've had several fistulizing Crohn's patients who did very well. And at DDW, there were abstracts highlighting fistulizing disease Crohn's patients who had very marked response and healing rates to upadacitinib. I think they're exciting. However, I think that the adverse event and risk profile we should be mindful of. You have to have been a failure or non-responder rather to an anti-TNF before you go on, because there's a 5 to 6% increased risk of shingles on the JAK inhibitors, which can be ameliorated by receiving a recombinant, varicella vaccine in the United States that is known as Shingrix. And then this very small risk, but serious adverse events of possible blood clot, heart attack, and stroke, which we think may possibly be a little less with selective JAK versus non-selective JAKs, but we don't know that. And we still have to have, I think, UPA out for a lot longer in order to really know. So I think that the JAK inhibitors are a revolutionary class of medicine, tofacitinib and upadacitinib, but every patient's different and not guaranteed a response. How are you all using, well, actually, let me go back. Let me ask our patients, what do I know our 2 patient advocates here are very well educated and know about the JAK inhibitors. You hear of a non-steroid oral medicine that doesn't require an IV drug or refrigeration or maintenance of a sub-Q injection. How does that make you feel, one? And, tell me, what are your thoughts about JAK inhibitors, just that new agent being available for Crohn's?
Madhura, I want you to take that just from the
sure.
Indian perspective. I think it's very important to hear your thoughts.
Sure. So I'm going to say 2 things. One, I'm going to share what is it that I'm hearing, and then I will tell you what I'm thinking. The thing that I hear a lot in our community is just so much relief that there is an oral therapy. Automatically for patients, the minute you say something is oral, something is straightforward to take, the dosing makes sense, it's, twice a day, once a day, twice a day, possible to take it. It relieves so much anxiety because there's no IV involved, there's no injection involved, there's no refrigeration that you need to think about, and it's dirt cheap. So from a patient perspective, why not, right? Like I would, even though both Dr. Nandi and Dr. Ahuja have laid out such an extensive side effect profile and compared that our biologics actually seem to be a lot safer in many ways as compared to the small molecules, which are still trying to understand better. From a patient perspective, we see a lot of patients very excited about the oral small molecule, and completely understandably so. For me personally, yes, if I had an oral pill, I would take it provided that I knew I would absorb it. So for me, that remains to be a concern, especially because I have a lot of disease in the small bowel. I don't absorb very well. So I would be concerned that I don't have enough drug levels in my body with the oral tablet, as opposed to the adalimumab, which is extraordinarily painful. I will just put it out there. The biosimilars in India still hurt, and it is expensive and it is difficult to store, but I know I'm absorbing it. So from that perspective, personally, I'm a little bit tempered about how I feel about the small molecules, but if I felt more assured that I would absorb it well and I would maintain the drug levels throughout, regardless of my disease status or absorption impaired status, I would be down for it, given all of the other infrastructural and financial barriers, especially in a country like India, which makes it very limiting to use a biologic therapy in the long-term context as well. Tina, how do you feel about it?
I actually completely agree with you. I've every time I have to give myself the ustekinumab injection, it's like a couple of days of working up the will to give myself an injection. You know what I mean? So I do understand where patients are coming from, having to go for an infusion, especially in a resource-limited setting where infusions are not as easily available, or even during COVID in the United States or in the UK, for instance, where we weren't able to access our infusion centers and had to figure out a home infusion situation. So infusions are a little tricky. Subcutaneous injections, you do need training. And I do feel like I struggled with it for a long time. I'm not going to lie about that. Pills are definitely easier, but I do have a shortened bowel. I don't have any colon or rectum, and I don't have a terminal ileum and parts of my small bowel. So I have serious concerns about absorption of pills. I often, this is TMI, but I often see things come out, and I would rather probably be on an injection just for my own sort of peace of mind. That said, I've been on ustekinumab since trials 8 years ago, and I'll be honest, the fact that we have new options like upadacitinib in the United States, I know it hasn't really been approved anywhere else yet. It's just such a recent approval. And same thing with risankizumab, which was just approved, I think, last year for Crohn's in the United States, also not available anywhere else. It gives me a lot of hope, because I was really worried for a number of years about what would happen if I keep needing more surgery. So there's a lot for us patients to look forward to. We have infusions, we have injections, we have pills. There's a lot of different options, like Dr. Ahuja was saying, and that gives me a lot of hope.
Let me use this as a great opportunity to use both of your comments to kind of reflect upon them, and then pivot back to Dr. Ahuja as we entered the last quarter of our talk here. But something that Madhura pointed out, which and you both pointed out, two things actually. One was the safety of the biologics when you look at the JAK inhibitors. JAK inhibitors are very safe, but we have to split hairs as clinicians and as patients about these different medicines. And I think one thing that I've learned as an IBD specialist, and Dr. Ahuja, I'm wondering your experience on this too, is that the biologics have been incredibly safe for the overwhelming majority of my patients. Now, does that mean that there haven't been other side effects or complications? No, I can't tell anybody that. If you practice long enough and you take the medicine long enough, things can happen, but most of those things are treatable and manageable things such as infections or whatnot. However, the majority of my patients have benefited. So I really truly believe the biologics are a very, very safe option, and address the second point that both Tina and Madhura brought up, which is any questions about gastrointestinal motility or short, having a shorter length of bowel to absorb, you can bypass that by getting IV or subcutaneous medicine. So it's exciting. We have to have a balance between oral, how much absorption we are capable of, and our ability to tolerate short of needle phobia, right, which is real, of IV or subcutaneous drugs. So now let me come back to Dr. Ahuja. And we have so much more. We could fill hours of conversation with you, Dr. Ahuja, but I have a bunch of questions coming in. And so they're not going to be needs. They're going to be kind of random questions. Okay. But first I'll ask you, in South Asia, how do we as a patient balance the risk? You mentioned tuberculosis, right? Some of the biologics, not all, may reactivate dormant TB. And sometimes TB may masquerade as Crohn's. Just as succinct as you can, how do you navigate that with the patient when working them up or treating them or putting them on a biologic?
So in US, this is what you said is very right. When I talk to physicians from US, they feel very comfortable with biologicals and being there in the sense that the safety element is very good. But let me tell you, in India, they are safe. Yes, but at the same time, you have to be very careful, much more careful than in Western countries when it comes to infections related to biologicals. TB, I say, is the easiest of infection to diagnose and treat when it comes to biologicals, because we have grown up with TB and Crohn's and biologicals, all three of them in a way. So TB, we have evolved a strategy, that is we do 2 or 3 tests, which is mandatory for all patients who are started on anti-TNF, or even if they are being started on ustekinumab or vedolizumab. That is, we do a skin test, which is known as the Montus test. Then we have an interferon gamma release assay, which is a blood test. And we would do a CT chest, not a chest test, a CT chest. And anywhere you find that there is evidence of old TB, you will be going towards liberal chemoprophylaxis in terms of starting INH for a few months. And that has really led to a lot of risk reduction in terms of TB reactivation. That strategy has been very useful. The problem arises is when some kind of unknown infections set in. Then it becomes very difficult to diagnose such kind of patients. So for biologicals, generally, what our strategy has been that we always advise the patient whenever there is any fever, even if for 1 day or something, they have to immediately report to us. One. Number 2 is that any patient who has been having many courses of steroids in the past, there's a high risk of super infection setting in after biologicals. So we want to monitor the patient very rigorously. Now, in terms of the third thing is how to differentiate between tuberculosis and Crohn's disease. That's a whole separate thing by itself in South Asia. You would it's a kind of case material for you. Out here in a given week, I would be sitting with 10 cases where me and my team would be scratching our heads. Is it tuberculosis? It is Crohn's disease. So we have developed an algorithm on the basis of which we try to make out whether the patient has TB or Crohn's. And whenever we feel that we are not very sure, we give a trial of anti-tubercular therapy so that at least we are on the safer side in terms of not doing any harm, and at the same time giving some drugs and seeing whether the patient benefits from that. If the patient benefits, yes, it is tuberculosis. The patient does not benefit. Within a period of 8 to 12 weeks, we try to switch over the therapy and move over to making a diagnosis of Crohn's disease. So it is something like that. But yes, when it comes to infections, the infection rate is slightly higher in India as compared to Western countries. So the physicians have to be more careful. The patients have to be more vigilant. That is, the moment there are certain telltale signs, they have to report to the physician immediately.
Yeah. If I could very quickly add to what Dr. Ahuja just said, I cannot agree more and cannot emphasize more the importance of being in close contact with your gastroenterologist, especially if there are any symptoms. I think, we have a tendency to be like, we deal with so much and we have so many symptoms that a mild fever is not necessarily the top of our mind concern, but it can cause challenges. It can cause complications that we don't want. So it's very important to report as soon as possible. And I would also add health maintenance. We don't necessarily talk a lot about taking the flu vaccine or the pneumococcal vaccine. And now we have Shingrix that has just been launched in India as well. So I would strongly encourage all of our patients tuning in to please talk to your doctors about the annual flu vaccine. how frequently you need a pneumococcal vaccine, and if you would be a good candidate for the Shingrix vaccine as well. I think these all provide us some protection against infections that are prevalent. Over and above that, masking, being careful about water, there are multiple strategies that we all evolve with practice and with the experience of falling ill by making a stupid, food decision, or like hanging out with people who have infections. But I think we live and we learn. And the most important takeaway is to just make sure that your gastroenterologist is looped in so we can get the best care that we need in a timely manner.
So quick summary points. Tuberculosis has prevalence all around the world, in South Asia and even here in the US, however, commonly there. The great thing is that in South Asia, we have leading clinicians and team members like Dr. Ahuja and one of our other research board members, Dr. Vishal Sharma, who have done good work in developing these algorithms and can manage TB. Don't let that be a barrier. If that's a concern, it should be discussed and can be managed, can be monitored. All the biologics are not created equal. Our anti-integrin, vedolizumab, does not increase or reactivate tuberculosis. So that's a very good option and available. Next question, because we have so many questions and little time. One of our community members asked, what is the efficacy of enteral nutrition for Crohn's? It seems to have almost 90 to 100% efficacy in pediatric IBD, but pediatric Crohn's, we don't see a lot of adults on it. Where is the use of that particular type of nutrition as a treatment, and why is it not more widespread? Dr. Ahuja.
So we use enteral nutrition in two settings, right? One is that, let us say we have to start the patient on biologicals, or the patient is malnourished, right? Serum albumins are low. So there we put the patient on exclusive enteral nutrition in the form of the liquid formulas for 4 to 8 weeks. So which acts in two ways. One is that it not only increases the albumin levels by providing good nutrition, it's a complete meal by itself, but it also decreases the inflammation. And then subsequently the drugs seem to act better. Second is that when we have tried everything, and then we really don't know what to do. We have tried this biological, whatever is available, we have tried that, it is not acting, right? Then in those cases, we move over to, at the same time, some of our patients who just cannot afford anything at all, and there is something we can arrange from the hospital in terms of enteral nutrition and all. So there we put these patients on enteral nutrition, because let us say, and add things like methotrexate and all, and then again in a way which helps in providing therapy. Some of our cases of fistulizing Crohn's disease, we put them on hyperbaric oxygen therapy, since those chambers are free, is available in our hospital, and our hospital does not take any charges for any such sessions. So those, along with enteral nutrition, there it helps. The problem with enteral nutrition is, again, to some extent, the cost. The cost, even after good negotiation, works out to in India to be, let us say, 500 or 600 rupees a day, right? That would be around $8 or something like that. Second is the retention rate. How much can a person live on? For how many weeks can a person live on enteral nutrition? Just 4 weeks, 8 weeks, not beyond that. So thereafter, we do step down to partial enteral nutrition. That is okay. You have some food, you may have an exclusion diet, along with that add partial enteral nutrition, so as to build up the albumin. But what we have seen is wonderful results, even though this is something which has been always considered as a therapy for pediatric age group, where they said that it is as good as the steroids. But in adults, I think as an adjunct therapy, it's an excellent therapy. The only issue is that for how much time a person can take it. If somebody takes it for 4 to 8 weeks, it definitely helps them bridge the tough times, which whenever the disease is in a major flare.
Yeah, I think that's great. Once you've had desi food, there's no going back, right? It's hard as an adult, right, to live on total enteral nutrition alone. Tina, what were you going to say?
Yeah, that's actually exactly what I was going to say. Like, when I was going through a very, very difficult time, I did have to go on total parenteral nutrition, which was a bag that was hooked up to through my arm and through a central line in my neck and in my chest. And that it's totally, I want to make sure I address this as well, and then have Madhura also address this quickly, because she's had a lot more experience on enteral nutrition than I have. There's nothing wrong with needing total parenteral nutrition. I know this was hugely stigmatized when I had to carry around a backpack with a bag full of fluid feeding me. This was very challenging. I was very underweight. I kept being asked, do you have an eating disorder, Tina, or something, but these are the things that will bridge the gaps to get us better. Like Dr. Ahuja said, this can be very, very helpful adjunctively, especially for children, yes, even as adults, but yes, temporarily, mainly because we have been exposed to other foods and, we crave those other foods. It could be very challenging for us to be kept on some of these long-term enteral nutrition sources when there's other food that we can be eating and be well nourished by. Madhura, please, I know you've had a lot of experience with this, so please weigh in.
Yeah, so I've had enteral nutrition orally and via feeding tube, and I've done the exclusive enteral nutrition, and I'm on partial enteral nutrition now. And I agree with what both of you are saying. For me personally, it has been a phenomenal adjunctive therapy along with methotrexate and along with adalimumab. And it has been a steroid sparing therapy. And I want to emphasize this because there is a lot of concern that we have as patients about the side effects of steroids. We've all experienced it. They are really challenging to live with. Enteral nutrition, in my experience, did not have side effects. It was a very comforting, in many ways, it was very comforting to have the benefits of a steroid without the side effects of the steroid. And I agree, it is challenging, but my perspective is a little bit different. I think when you're so sick, and you are, say, for instance, when I went on exclusive enteral nutrition, I was having blockages and I was finding it very difficult to eat orally. And it was becoming a challenge where I was losing weight so rapidly and it was becoming very hard to manage. For me, exclusive enteral nutrition actually addressed the symptoms, yes, but it also made me feel better. And the fact that I was feeling better kept me adherent to that therapy. It kept me on it for the 4 weeks that I had to be on it. And ever since I've stepped down to partial enteral nutrition, either via feeding tube or orally, I remind myself that partial enteral nutrition takes care of my daily nutrition needs, which means the rest of the time I can eat as I please. I can eat the foods that I like. I can eat the foods that make me feel happy without worrying that I'm not absorbing enough nutrition, without worrying that I'm going to lose weight because the partial enteral nutrition is taking care of it. And I know that this is highly stigmatized, and I know that many patients have concerns about the ingredients that are there in the enteral nutrition formulas. All I can say from my personal experience, from speaking to my doctors and from all of the research that I've seen, is that enteral nutrition therapies are very safe, they're very efficacious, and they have the potential to give you your life back in a way that you may not recognize just looking at a formula box or the formula liquid.
100%. I think we've highlighted a couple of things here, right? We've talked about early therapies like thiopurines, 6-MPAs, thiopurine, methotrexate. We talked about the prednisone steroids and how we've evolved to biologics, small molecules like the S1Ps and JAK inhibitors. And then also that we've really embraced and known all along, but really embraced, and science is taking off and looking at nutrition as therapy, right? And trying to harness these elemental therapies or partial elemental nutrition to get our patients into a better remission. I love the fact, Madhura, that you reminded us that elemental diets can be part of, or enteral diets can be part of a steroid-free regimen, right? That's huge. So again, in our last few minutes, let me just address one or two other things. And I wish we had more time. I know the four of us could talk forever about this, but I want to respect Dr. Ahuja's time and our community's time. In 2023, Dr. Ahuja, you said this, right? 10, 15 years ago, we could not have imagined the world that we live in now, right? There's never been a better time, an exciting time for me to help take care of patients, and for patients to have IBD. There's more hope than ever, right? But what we have these therapies, what are the suggestions or tips you can provide on access, right? Financially, this can be challenging. Do the companies have financial assistance programs, or, how does one manage the financial access to these treatments and therapies?
So I can talk for India in a way one thing is, okay, if you are very rich, then obviously you don't need to manage. If you're very poor, then you don't need to manage in India. Because in India, if you are very poor, you have a below poverty line card. So below poverty line card gives you access to biologicals infinitely, like for how much time you require, the government would pay for it. But most of the state governments I've seen, like I went to Rajasthan recently, then I went to Chennai, and then I went there. So I realized that most of them are giving at least 3 doses of biologicals free to all patients, and some of them are giving it even beyond that. Then we have, besides that, Ayushman scheme, but Ayushman scheme has still not taken a biologicals as yet. But as per my last discussion with the chief out there, they are actively planning to include it, and hopefully, if they do it within 2-3 months, that will be another great service for the patients. There's a scheme called as Ayushman scheme, whereby free medication is provided by Ministry of Health for the government of India to all the patients across. Then we have the biosimilars which are available in India, which are at least 3 or 4 brands for infliximab as well as adalimumab. Definitely, there's a 30 to 40% cost cutting out there, and they are as efficacious as original molecule. Then for small molecules, as the word which was used by Madhura was actually the apt word, they are dirt cheap, in the sense that if the cost is really like 5 ASA or something like that. So if you have upadacitinib, which is available, and tofacitinib, which is already available, and the same way UPA comes up, then you have one drug for ulcerative colitis where you do not have to sit down and think, oh, what do I do now? For any patient. Not any patient of ulcerative colitis comes, we are very relaxed that at least, if nothing else, we can give tofacitinib, even if the patient cannot afford anything. But for Crohn's, we are stuck because we do not have that kind of substitute. And the moment UPA comes up and we have the generic forms, then they will feel comfortable, okay, that we have a very good option for the patient, even if they can't afford anything. Then we have the industry-driven, the pharma-driven patient schemes. For example, Takeda, they have a patient assistance program, where in India, I think they give somewhere roughly around 2 to 4 or 2 to 3 to 5 injections a year free, depending upon the financial condition of the patient. And Stellara has also the Jensen, the ustekinumab people also have a patient assistance program where they give, I think in induction dosing, they give one of the vials free. So that way, there are avenues which are coming. For example, if today at our center, there are 200 patients who are on biologicals, you'll be surprised to know that around 150 of them would not be paying from their pocket. Around 100, 120 would be below poverty line. 30 of them would be working in government, railways, army, or somewhere. So they would be getting from there. And so that's a sizable number in terms of people who are getting today biologicals, which they have access to them. And obviously, the small molecules is like the icing on the cake, which really makes things easier. So things are opening.
If I
That's
could
terrific.
also add to what Dr. Ahuja said, I think he's covered, the gamut of all of the financial assistance programs that are available in India. If I could add from a patient perspective, I would say speak to your gastroenterologist. Sometimes it's very hard and it feels very uncomfortable to talk about financial matters with somebody who's not a member of your family. But our doctors are there to help us. They are there to find avenues to keep us on these medications. And I feel that when we discuss our concerns openly, say, am I going to need to stop this therapy because I can't afford it any further? They are there to help us. So I think for us as patients, it's very important to feel comfortable speaking with our gastroenterologist and say, look, doctor, this is my situation. Can you help me? And how can we together as a team of patient and physician bridge this gap? And the other aspect I would add is that there is some power in collective bargaining. If there are many patients who are on a particular medication, say adalimumab or infliximab in the same city, who are buying from the same distributor, there is some power in coming together as a collective of patients and bargaining for slightly lower rates. That is an option that I have used. That is an option I've seen other patients use effectively as well. So these are some strategies that exist outside of what is structurally available to us as well.
And if I may add another thing out here is that there are some phase 4 clinical trials which keep on running in India.
Yes.
For example, we had recently the vedolizumab phase 4 clinical trial. So we always have a list of patients who require biologicals, are not able to afford them. And whenever we see a good phase 4 or a phase 3 clinical trial, for example, we had a phase 3 clinical trial of ustekinumab versus IL-23 inhibitors, or we have phase 4 trial of ustekinumab, which is coming up. We recently was the phase 4 trial for vedolizumab. So we have those lists ready for the patient with their phone numbers, and we tell them, okay, wait for 2 months. If the trial starts, those are kind of phase 4 trials where obviously there is no element of, in a way, that there's a post-marketing kind of work which is going on. So they can safely get included in these trials, and they'll benefit a lot by getting it free of cost for 1 year or 2 years, like that.
So, Professor, you read my mind. I was going to bring up trials, and thank you for addressing that. I appreciate that. Here in the States, in terms of access, we do have a lot of patient assistance programs from the different industry companies. So if you have depending on the tier of insurance that you have, you qualify. And ironically, if you don't have the best type of insurance, you don't qualify. So if you have Medicare, it actually hurts you in terms of access. But there's still other financial programs that the different industrial companies do provide. So there's always a way working with industry and insurance and advocacy that we can find access. And it sounds like the true is the same there in South Asia too, which I'm really, really happy to hear. So we have so much more to discuss, and we got a lot of great questions from our audience that we could not even get to. So if you asked a great question, I'm very sorry we didn't get to hit it, but we will try to do so in another live. In fact, our live stream programming for the rest of the year is very, very comprehensive. So please stay tuned to our agenda as we push things out. Please do feel free to speak up and put things into the chat about future questions, because we do look at those questions and try to accrue them and incorporate them into future lives. Before we close, I'm going to start with our patients first, and then Dr. Ahuja, you get the last word, but any closing comments about the new medications and access from Madhura or Tina?
Happy to go first. I think when we think about treatments, we think about side effects. It's a natural reaction for every patient to have. I hope this talk has illuminated us about what are the possible benefits of these treatments. I would say when you're introduced to a new treatment, think about focus on the definitive benefits that you have rather than possible side effects. And remember, not treating your disease is an adverse event. It is a side effect as well. So when your doctor is offering your treatment, that is the important side effect they are keeping in mind, because they want to treat your disease. They don't want you to be sick. So definitely focus on what can we gain from a biologic therapy or a small molecule therapy or thiopurines or methotrexate, and focus on that and ask your doctors and advocate for yourselves for a greater quality of life and better health. Tina, what do you think?
Yeah, no, I totally agree with you, Madhura. Thank you for sharing. And thank you so much, Neil, for moderating, Dr. Ahuja for joining us today. I would say to our patient community, I know that some of these therapeutic options and the way that they may sound as biologics, as infusions, as injections, may appear scary to us at first thought. I was scared. My family was scared. But I think that, what Madhura said is very true, that leaving my disease untreated or undertreated was actually the biggest adverse event for me. And delaying surgery was an adverse event for me. These things lead to complications that may never need to actually happen. And I know we worry about side effects, but side effects often don't always happen either. And that was something I was scared about going on a biologic. And I can reassure you, I really haven't seen many side effects at all the last 8 years that I've been on this biologic. So I just want to put out there, a positive message. There's a lot of new medications out, a lot of new therapies out. We receive a lot of questions around alternative therapies, even with this chat we did. And I implore you to speak to your physicians openly about these alternative therapies, and if they can be adjunctive to your mainstay treatment for your IBD. But please don't leave your IBD untreated or undertreated. Thank you.
Thank you, Tina. Thank you, Madhura. And Dr. Ahuja, what are your last parting words of wisdom for us?
First message for the audience is that Dr. Nandi is the best moderator. Madhura and Tina are the most knowledgeable patient advocates as well as experts, and all three of them have a lot of passion in terms of taking care of IBD patients. So all of you should tune into every session of theirs. These are very useful sessions, very inspiring sessions, and very educative sessions. So please do tune into. My second message is that when I was a medical student, hepatitis C was discovered. And over the years, by the time I became a professor and subsequently they had discovered a cure for hepatitis C virus, which we never thought when when we were medical residents, that, oh, hepatitis C would get cured. We always thought it leads on to cancer, it is so bad and this and that. Similarly, IBD is something which at least in the country came up when we were students. Earlier, Crohn's disease possibly people thought never existed in India or something like that. But the flurry of research which is going on with the the trajectory of new molecules which they are coming up, as Tina talked about, I would not be surprised if in 5 years or something they find out the magic bullet which will nip the disease completely. And we look forward to that day, and I'm sure it is going to happen the way things are. So thank you so much for inviting me, and thank you. It was a wonderful feeling to be part of this program.
Thank you, Dr. Ahuja. We are truly blessed to have you on the program. We've been looking forward to hearing you speak and sharing some of your insights. And I think that a lot of the things that you related and taught today really are going to help a lot of patients better understand and hopefully be more comfortable about talking to their gastroenterologists about these new therapies. And I think the most important voice in every room, I say, is the patient voice. So I can't thank Madhura and Tina for speaking up on behalf of everyone and sharing your personal experience with the greater community. The impact that all of you make is huge. So I'm going to conclude in just a few moments here. I want to thank everyone listening in. You're probably a patient or a partner or a parent or a child of a loved one, right? Not just patients tune in. We at SAIA are dedicated to elevate the knowledge and advocacy and destigmatization of inflammatory bowel disease. We want to empower you with the best education possible, give you the resources that you may not have, and start the conversation about how to make you feel better, get better. Remember, if you're a patient, you deserve better. Don't settle. There are more options than ever before. There are wonderful specialists like Dr. Ahuja, who you can speak with and seek. And he trains so many great people to help elevate the quality of care for our patients with IBD. And remember, you have a community. Here at SAIA, we host IBD Desis, our Facebook support group, where we have a community of South Asian patients like none other who have inflammatory bowel disease. We support one another. I can't thank you enough for tuning in for SAIA's first episode of season 2. I hope you'll join us for the remaining programs. And I want to thank our sponsors, Takeda, Lilly, Janssen, and Bristol-Myers Squibb, and Hollister for promoting and supporting SAIA. Thank you so much, and we'll see you in the next live.
Thank you.